All right, good morning, good afternoon, good evening, everyone, depending on your time zone. My name is Godwin Pius Ohemu, and it feels really good to have every one of you with us on the call today. We are gathered here to commemorate the World AMR Awareness Week, and today we are in Asia. Yesterday we were in Africa, and we had a very nice conversation on how to mitigate antimicrobial resistance in Africa using the One Health approach. Today, we are in Asia and we are going to look at how we can equally mitigate the challenges of antimicrobial resistance in Asia using the One Health approach. So I really want to welcome every one of you and thank you so much for making our time to be part of this great conversation. As we start, I would like to quickly make these few announcements with respect to housekeeping. I'd like to let you know that this webinar is being recorded and the recording will be shared on the Global Health Network platforms. Due to the number of participants on the call, your cameras and microphones are disabled. And we really will be very grateful if you could use the chat function on your screen to introduce yourself. We really would like to know who you are and where you are joining us from. So please use the chat box to tell us your name and introduce yourself and get to connect with colleagues on the call as well. And then we have a session for Q&A, which will be as soon as the speakers are done, we could take Q&A. And if you really want to ask a very burning question, you can use the Q&A box on your screen, drop the question, and the speakers will do well to either type their response to the question, or when the time for Q&A comes, they will be able to give response to your question as well. This is how the event is going to go. And then just a quick look at how many persons registered for today's event. As you can see on your screen, we have a very large number of persons who have expressed interest in today's event, and we are very grateful that you made our time to be part of today's webinar. This is the panel and the agenda, and these are the individuals who are going to serve in one capacity or the other in today's event. I will serve as the chair of today's event. I work as the graduate assistant at the Antimicrobial Resistance Knowledge Hub and Community of Practice of the Global Health Network. My colleague, Hamza, who is a consultant for the Global Health Network, will give the welcome remark as soon as we make a start. And then after that, we'll have Dr. Anuj Sharma, who is the technical focal point, AMR and IPC for the WHO India. He's going to give the first presentation for today. Then afterward, we'll have Professor Gitanjali Kapo, an AMR consultant India, and also a visiting academic of the University of Oxford. So this is how the event is going to go. Then as soon as Professor Gitanjali is done, we'll have Dr. Tin, who is the strategic advisor, the Global Institute, University of Copenhagen, and also an advisor for the Global Health Network and a former AMR program coordinator for WHO. So these are the individuals who are going to serve in very, very important capacity in today's meeting. And then as soon as we are done with the presentation, we'll take the Q&A, and then we'll have the closing remark. And my colleague Nana is on the call, who is serving as the scribe for today's event. Having said that, I would like to make welcome my colleague Hamza for her to make the opening remark. Hamza, if you are ready, we are ready. Over to you. Thank you. Hamza, if you're on the call. Okay, sorry about that. I think my colleague is having technical glitch on her end. Without further ado, ladies and gentlemen, I think I have to make the welcome remark on my colleague's behalf. The World AMR Awareness Week is an event that is observed every year by the WHO. It is an opportunity to raise awareness on the upscourge of antimicrobial resistance in different settings. And via webinar, the Global Health Network organize this gathering so that individuals could come share their knowledge on the subject matter of AMR and see how we could leverage the One Health approach to mitigate this challenge in our localities and in our various settings. So today we are in Asia, as I said earlier, and we really appreciate everyone for being available, the resource persons who have been carefully selected to make a presentation in one capacity or the other, and to everyone who are on the call as participants. We are glad that we are here, and we really thank you so much for coming, and we hope that you have a wonderful time with us. Having said that, without wasting any bit of our time, I would like to bring to the fore our first speaker for today, who is Dr. Anuj Sharma. Dr. Anuj Sharma is the technical focal point AMR and IPC for the WHO India. I'll stop sharing my screen so that Dr. Anuj can share his screen and start his presentation. Dr. Anuj, if you are ready, we are ready. Over to you now. Thank you.
A very good afternoon, good morning, good evening to all the participants of this webinar. I will talk on AMR commitments and initiatives at the subnational level in India. All of you would be aware that antimicrobial resistance needs action across sectors and across disciplines, across a large number of stakeholders. And in India, we do face a large number of challenges. We have a high burden of communicable diseases. We have the largest consumption of antibiotics in the human health sector. A lot of antibiotics are available over the counter in few states, despite regulations. Also, quality of antimicrobials at times is an issue. Infection prevention and control and water sanitation and health and access to quality healthcare services is a challenge in few areas. And we have high levels of AMR with limited representative AMR surveillance across sectors. This is coupled with low awareness about AMR amongst the public, with over-the-counter use as well as prescription sharing, and also the challenge of intersectoral coordination and the issue of overuse and misuse of antibiotics across sectors. But a particular challenge is prioritization of antimicrobial resistance in states and union territories of India. India's National Action Plan has 6 strategic priorities, and these mirror the Global Action Plan, the version 2, the second edition, which is under development. Earlier Global Action Plan had 5 strategic priorities, but India had one on coordination and collaborations, and the Global Action Plan 2, second edition, also has a 6th strategic priority on governance, coordination, and collaborations. Out here, in addition to international, national, subnational, the state AMR action plans are critical. And yesterday, we were fortunate to have the launch of India's NAP AMR 2.0 in the health ministry. The reason the subnational or the state action plans on AMR in India are important is because the states and union territories in India are in a federal system of government. And under the Indian Constitution, we have 3 lists. And the state government, if you see, the state list has all the sectors which are important for AMR containment: human health, animal health, fisheries, agriculture, water and sanitation. And of course, the state governments also have responsibility, joint responsibility for the food sector, drugs, and education. Therefore, state action plans for containment of antimicrobial resistance are extremely important. And I'll take you through a couple of examples how states are, working on these initiatives. Second strategic priority is surveillance of antimicrobial resistance. And out here, the National AMR program, coordinated by the National Center for Disease Control, has 2 major networks. One is the NARSnet, the National Antimicrobial Resistance Surveillance Network, and the National Antimicrobial Consumption Network. The NARSnet uses WHONet to compile all the data from the network sites. And accordingly, we partnered with the state governments and NCDC to establish 3 state AMR surveillance networks in Maharashtra state, Kerala, and Delhi. So these 3 state surveillance networks, so over the last 5 to 7 years, have matured and have now are part of the NARSnet. And NARSnet has actually also established state AMR surveillance networks in Rajasthan, Puducherry, and Gujarat. Gujarat has the particular initiative of having One Health AMR surveillance looking at genomics, which is entirely a state government initiative, but the human health data flows to NARSnet. Second key focus area where the state action plans and the state governments have made a difference is infection prevention and control. We partnered with the National Center for Disease Control to develop the national guidelines for infection prevention and control in healthcare facilities. And by the time these were launched, the COVID pandemic had arrived, and a lot of our efforts were focused on COVID IPC trainings, and we use these COVID IPC trainings to push to strengthen infection prevention and control in healthcare facilities across India, followed by national level training of trainers on IPC, where we had state nominees from all states participating in various networks. But then subsequently, a number of states also developed state IPC plans and state training of trainers, starting with Kerala, Madhya Pradesh, Chhattisgarh, Assam, and Maharashtra. And the aim is to cover all the states and union territories of India. Now, the third area that I will focus on is the state action plans for containment of AMR, which is extremely important because the state governments have a huge role to play in AMR containment. The first state to launch their state action plan was Kerala. CARSAP was launched by the Chief Minister of Kerala in the presence of the Health Minister and the Additional Chief Secretary Health. Second state to go in was Madhya Pradesh, followed by Delhi.
Dr. Anuj, we just lost your audio there for a second. Looks like you've muted yourself.
Sorry.
Thank
you. Am I audible now? Yeah. So not only was Kerala the first state to have a state action plan, they also have a Kochi Declaration on One Health Action on AMR endorsed by the veterinary sector, the animal husbandry minister. Also, the Project Amrit, AMR in total health, has implemented the ban on over-the-counter sale of antimicrobials, leading to a saving of 1,200 crores Indian rupees in just 1 year. And also, they have started aware-based reporting of antimicrobial susceptibility testing so that they can focus on access group of drugs and their target to achieve, they want 90% of the antimicrobials to be used in Kerala from the access group. They also have an initiative on antibiotic smart hospitals, first state to have an environmental AMR lab to monitor AMR and antimicrobial residues. They have a program for return of unused drugs, and they have a literacy program in local language and English, in which they have roped in district and block committees and the frontline workers called ASHA. Also, they are using the World Bank project on One Health to push for AMR as well. Also, Kerala hosted the regional SAPCAR workshop along with the Ministry of Health and WHO, in which we had the southern states and union territories participating in Feb 2020. We also organized state action plan meetings and workshops in Delhi in 2022, first with REACT and the World Animal Protection, and then with the Center for Science and Environment. And these really helped push the development of AMR action plans across India. And also, Andhra Pradesh was the 4th state, followed by Sikkim, then Gujarat, and then Rajasthan. All of them, these are state action plans developed with a One Health approach, with the leadership of the state government, of course, aligned to the National Action Plan, but also having strong ownership and a responsibility of the state government. Punjab was the 8th state to develop to launch their state action plan in September. A number of other states have either developed their state action plans awaiting formal endorsement, or state workshop have happened and they are in various stages of developing their state action plans. Now, if you look at some of the best practices from the states and the union territories across India for subnational level, oversight and prioritization by policymakers has been seen in Kerala and Karnataka. Karnataka, the health minister is pushing the AMR action plan. In Kerala, it's the chief minister, health minister, and the bureaucracy. Coupled with the designated AMR focal points, they have more than 15 designated AMR focal points with allocated responsibilities who look after different aspects of AMR containment across all sectors. Also, they have the Kochi Declaration. Madhya Pradesh has a policy declaration by all the ministers called the Bhopal Ghoshna Patra on antibiotic resistance. Stewardship by advisors and influencers also helped push the agenda in Kerala, Karnataka, and Andhra Pradesh. Now, the advisors to the chief minister in Kerala, the physician who's also the convener of the state AMR action plan in Kerala, the advisors to the health ministers, chief ministers have really pushed the agenda forward in a lot of states. Also, some of the states have designated AMR focal points, Kerala being the first with nearly 15 of them, Gujarat, Andhra Pradesh, and Maharashtra as well. And if we look at AMR governance committees and mechanisms, all states have AMR governance mechanisms and committees. But monitoring of the state action plan is being done only in Kerala, where they monitor the actions every 3 months. Every quarter, there is a review meeting chaired by the health secretary, followed by a 6-monthly meeting by the health minister and an annual review by the chief minister. 2 other key things which have happened at the subnational level is AMR surveillance networks have moved from a project mode to a program mode in Maharashtra, Kerala, Delhi, and Gujarat. Also, the state IPC trainings and plans have also moved into program mode in some of the states. Of course, Kerala, Madhya Pradesh, Assam, and Maharashtra. Again, just to remind you, there are a large number of stakeholders in India. This is the list of the key stakeholders in India. On the left-hand side, you have the 4 key ministries. We have the overarching Niti Aayog, the National Institute for Transforming India, and the principal scientific advisor to the government of India. They also play an overarching role with a large number of ministries on the right-hand side. Of course, professional councils, medical colleges, hospitals, veterinary colleges, hospitals, professional associations, civil societies, and non-governmental organizations, research organizations, of course, the private sector, students, and of course, the state governments and union territories. A lot of these stakeholders have state analogous departments at the state level. So again, a huge number of stakeholders. And at the national level, we work closely with FAO, UNEP to form the Indian Quad Tripartite or AMR, and we work closely with other donors and partners. So this is just to share a lot of initiatives are happening in India, not just at the national level. We had the launch of the National Action Plan yesterday, but AMR is everybody's business. And we need a lot of stakeholders to work across sectors, across disciplines, across facilities. And also the role of the influencers and the AMR champions in pushing AMR agenda at the national and the state level is extremely important. And all the AMR response is guided by the 6 strategic priorities of the Global Action Plan, the National Action Plan, and the state action plans, which are well aligned. And I would like to end by saying AMR is everybody's business, and it's time to mainstream AMR in all programs. Move from a vertical approach to a horizontal approach where AMR is integrated in all programs. Thank you.
Thank you very much, Dr. Anuj. That was spot on. Honestly, that was spot on, and we are very, very grateful. As he said, antimicrobial resistance is everybody's business. It is not just the business of the government, it is the business of all sectors, private sector, public sector, institutions, everybody, households, religious centers, everybody needs to get on board in the fight against antimicrobial resistance. This is excellent, and I want to say a big thank you for making our time to make this presentation. Ladies and gentlemen, if you have any question you would like to ask Dr. Anuj, we request that you put the question in the Q&A box. He's going to attend to them, or better still, at the end of all speakers' presentation, we can take the Q&A if there is any pressing one that you really want to air out to him. So please use the Q&A box and let's receive your question. Without wasting any bit of our time, we are going to jump in straight to bring to the fore our second speaker for today. Our second speaker for today is Professor Gitanjali Kapoor. Professor Gitanjali Kapoor is antimicrobial resistant consultant in India, and she is also a visiting academic of the University of Oxford. Professor Gitanjali, I'll stop my screen and then you start sharing and make your wonderful presentation. We really can't wait to learn from you as you just did from Dr. Anuj. The central message is antimicrobial resistance is everybody's business. Let's hear and let's see what your own call to action line is going to look like. Thank you very much, ma'am, and welcome.
Thank you for giving me the opportunity to take part in today's webinar. And of course, Dr. Anuj Sharma's presentation was excellent. It's always the best. So the topic I'll be talking about today is how to set up an IPC program. IPC stands for Infection Prevention and Control. And as we just heard, and as most of us know, IPC is a very important pillar of strengthening an AMR mitigation program anywhere, irrespective of whether it's a low resource or a high resource setting. So the agenda of my slide, I'll be going over lots of things in a very short period of 10 minutes. So please excuse me, it would not be too detailed, but the overview I would be providing to you. And right now on this slide, you can see the various aspects I'll be talking about. So let's deep dive quickly. Now, what are the various factors that actually lead to AMR? We all talk about AMR, and it's not just any one reason. There are multiple reasons. And as you can see on this slide, I've just tried to compartmentalize it into basically whenever you have lots of microbes or you have excessive use of antimicrobials, and of course, then confounding factors which actually come from the environment in most scenarios. So when all this happens, of course, the bacteria naturally is able to camouflage itself and come up with lots of resistance mechanisms. So a lot of factors to accelerate AMR. And on the right side of my slide, what you can see, let's start from the bottom. These are the various factors which I just mentioned. They would lead to rise in infectious diseases, including healthcare associated infections. And many of these would be due to resistant organisms. We commonly call it as MDRO, multi-drug resistant organisms. And of course, it has an impact on morbidity, mortality, economic loss. I think this slide, most of us know, the numbers we all know. So I'll not get into detail, but just for those who may not be aware of it, the review on AMR which was chaired by Lord Jim O'Neill and published in 2016. It's actually been quite a landmark study, and these numbers would stay until we have another, paper coming up. So as per this, the deaths attributed, so that's more direct, like attributed deaths due to AMR, in the year 2014, as per modeling studies, it was about 0.7 million. And then later, by the Lancet report, it was almost double. You can see 1.3 million deaths just due to AMR. Associated, of course, is a little bigger umbrella that's almost touching 5 million. Now, coming to how did the concept of IPC actually originate? This concept originated by a study called Senex study, which was done somewhere in 1970s, many years back. And that actually showed that infection rates are going to reduce with few interventions, which still stand true today. That means professionals like clinicians or microbiologists who are trained, dedicated infection preventionists, surveillance systems, and of course, IPC practices. So this is not a new concept. It's a concept that has always been there, and it's evidence-based. When we talk of IPC, it's not just one thing that you need to do. You have to do multiple things together. So it's not like doing just hand hygiene or standard precautions. Many things go together. So if you pick up any book or any document on IPC, you would actually have lots of chapters, because that all is within the umbrella of infection prevention. Out here on my screen, I'm just trying to show you the important ones. So if anybody does a course or training on IPC, you would, of course, need to be a master on all these various topics. So let's just quickly maybe deep dive into 2-3 of these. Standard precautions. We all know about standard precautions. Basically, there are two types, standard and transmission based. Now, what is standard? The name itself, it actually indicates that it needs to be followed for every patient always. And transmission based is especially, it's an add-on to standard precautions for certain specific conditions where we know that what is the route of infection. As example, for tuberculosis, it's airborne, or influenza is droplet. COVID was actually under the droplet category, airborne category. So according to that, you have to decide upon what is the additional precaution you need to take over and above the standard. Now, standard, it basically talks about hand hygiene. We all know about hand hygiene, and WHO has the moments of hand hygiene, which I'm sure all of us know about. Then the equipment we use to protect ourselves, we call it the PPE. And respiratory cough hygiene is important, especially in pediatric settings, because the kids may not be, very good with wearing PPE or hand hygiene. And safe injection practices. So these are the 4 broad things that come under the umbrella of standard precautions. What about transmission based? Now, again, not getting into too much of academics, but I think it's just important for us to remember the number 5. Anything that's less than 5, equal to or less than 5 microns, we normally call it as a droplet nuclei. And these are spread through air, and hence we need precautions which are called airborne precautions. And droplet is something which is more than 5. It normally cannot go for too long in the air, maybe somewhere around 3 meters. And hence for that, we need to follow droplet precautions. Just remember ABC for short: airborne, TB falls in this category. Droplet, that's going to be for plasma gas surrounding the patient in a room which is having isolation room, and for facilities which are very old, and of course you cannot maybe look into the number of air changes. The criteria so far is that anything which is up to 6 air changes per hour is acceptable. For the new constructions, 12 is recommended. Droplet precautions, basically you need to wear facial protection. Contact basically is to be followed if the patient has herpes, localized zoster, scabies. So these have to be more around taking protection, wearing gloves. Now, coming to standard precautions is one of, as I said, an important pillar of standard of IPC. And then we talk about environmental cleaning and disinfection. This takes into account, especially if an instrument or equipment is being used for surgical purpose, what kind of sterilization you need to do, or is it a non-critical item, it just touches the skin, you can just do away with a low-level disinfection. What about engineering control? When we say engineering, it basically talks about the kind of ventilation standards that you need to maintain to ensure that the positive room is under the right pressure or a negative is under the right pressure. So these things also, and of course, this is not something which only one discipline does. You need engineers who are specially trained to monitor the requirements and recommendations. Another sub-pillar of IPC is WASH. I think everybody knows about WASH, the importance, and this is something which we talk about in awareness programs. UNICEF does a lot of programs on WASH and vaccination. So this is another sub-pillar of IPC. Food safety, again, is important. If your food is hygienic, well prepared, the food handlers are regularly checked for any disease or infection, then of course it's important, and we do recommend it because it's going to ensure that the infection is not getting spread, it's getting contained at the point of source. Now, how do you measure the impact of IPC interventions? There are various ways. One of the ways is you can check upon the knowledge attitude practice, that means CAP, for the healthcare providers and support staff. You can also look into the compliance to various practices, which I just mentioned, and many more. And also the amount of resistance that's prevailing, that means the prevalence of the MDROs and the healthcare associated infection rates. Now on this slide, what you basically are seeing is on the left side, you see that if your infection prevention control strategies are good, then of course your MDROs and HEI rates would be lesser. So just it's like a seesaw. Steps of HEI surveillance. This is something very technical, and all you need to do is you can basically put this into practice in a high-risk area like ICUs or transplant units. So those are the high-risk areas. SOPs need to be created. We do have international guidelines, but they need to be customized as per your own geography. And there is a lot of information available which could be tapped upon when contextualizing as per your setup. A team needs to be trained. We call it the surveillance staff. They need to go take daily rounds and as per the SOPs, collect the data, put it into the database, which again goes for further analysis, analyze the trends. So very, very systematic process. But I think most important for us to know is that this is important. We must try to integrate it into our IPC programs. What are the emerging questions which all of you can, think about in IPC? It's just not restricted to hand hygiene or PPE or, equipment disinfection, environmental cleaning. It's beyond that. And COVID did, bring all that into light. Is it airborne? Is it droplet? There was a lot of to and fro's going on that. So these are areas where a lot of research still needs to go. Also regarding the environment's influence in spreading AMR, another upcoming area of research, particulate sampling. Instead of, nowadays they say you don't need to do environmental sampling anymore, but yes, you still do it in case of an outbreak or if you are developing a new policy or in certain research conditions. So yes, those are still emerging research areas in the field of IPC. I used a lot of references to put these things together, and it's out here, mostly from CDC, Jim O'Neill's article, and the World Health Organization. Thank you so much. I'll be happy.
Thank you so much, Dr. Gitanjali. That was spot on and on the time. really appreciate, the effort you've put in to prepare this lesson and to speak to us on how to set up IPC in various settings. Ladies and gentlemen, if you have any question with respect to Professor Gitanjali's presentation, kindly use the Q&A box, drop your question in there, and we are going to take them, or she will type responses to them herself while we jump in straight to the next presentation that we have today. Without wasting any bit of our time, I would like to introduce to us and bring to the fore our next speaker. Just give me a second. Let me put on my screen and then bring the next speaker on. Okay. So our next speaker for today is no other person than Dr. Tim. Dr. Tim is, oh my goodness. Okay. Yes, Dr. Tim is a strategic advisor for the Globe Institute, University of Copenhagen, and also the Global Health Network. She is a former AMR program coordinator for WHO, and today she's here to make a very intelligent presentation to us on the subject matter of addressing gender inequalities in national action plans on antimicrobial resistance. Dr. Tim, if you are ready, we are ready. Let's start.
So thank you very much for the invitation. Today I'm going to share with you work that was done in WHO when I was there on addressing gender inequalities in national action plans of antimicrobial resistance. Next slide, please. I'm going to talk very briefly about the global perspective of AMR, then why a gender lens on AMR is needed, and then talk about the work on the national action plans on AM and AMR and gender. So just, we already heard about the disease burden, but I just want to flag that in WHO has identified antimicrobial resistance as 1 out of 10 major health threats of our time. And our Director General, Dr. Tedros, has said that the growing threat can send us back to the time before antibiotics. And already AMR is estimated, I'll tell you when to swap slide, sorry, can you go back? Estimated to 5 million deaths every year. Also, it's emphasized that this major health threat can only be addressed by One Health approach, that AMR impacts every sector and that every sector must be engaged in the response. Also holding hands between the public and the private sectors, and of course across health, agriculture, and the environment. Next slide, please. So just to emphasize what WHO's objective is, it's the goal of having antimicrobial treatments that work today and also work in the future. Next slide, please. So just to go back a little bit in time, in 2007, the World Health Assembly adopted a resolution urging member states to formulate national strategies for addressing gender issues in health policies, programs, and research, and to apply a gender equality perspective in healthcare delivery and services, and to collect and analyze sex disaggregated data. This is still work in progress. Next slide, please. Just to clarify the differences between sex and gender, often, at least when we were doing the work, it became very clear that there's a lot of confusion. Sex is very much referring to the biological traits of men and women, whereas gender is the cultural defined roles and responsibilities within our communities. So as you can see in the middle, it's sex is biological, chromosomes, reproductive organs, genitals, hormones, which are things that make men and women more susceptible to certain types of resistance. Women, for instance, when giving birth, have a higher risk of sepsis. They also have increased higher numbers of urinary tract infections, whereas males may have other conditions that are more linked to their biology. But this is just a slide to clarify the differences between sex and gender. Next one, please. When talking about AMR, there are different levels where antimicrobial or infections and antimicrobial resistance may be relevant. There are the risks very much flagged in this slide, which shows how resistant bacteria circulate from a One Health perspective between human, animals, the food, agriculture, and the environment, flagging that there are risk factors. AMR has different risk factors when you stratify by gender, but you also have the biological differences in all the different aspects. So this is just to flag that the resistant bacteria circulate, and that different exposures and different biologies change the impact of resistant bacteria on human beings. Next slide, please. So coming back to the WHO work on addressing gender inequalities in AMR National Action Plan, this was work that was started in 2023, and this publication came out in 2024. And I can really recommend that you go and have a closer look at this, because it's really trying to give very concrete, actionable recommendations on how better to apply a gender lens to national action plans. So the publication is aimed at identifying and addressing gender-specific vulnerabilities, embedding gender analysis into AMR research, and promoting equitable access to antibiotics. Next one, please. So the structure of the document is that it has it's building around another document that is called a people-centered approach to antimicrobial resistance, and it has 20 recommendations around these. There are 3 overarching recommendations linked to data for action, research, and gender in national action plans. These are structured in 5 pillars that are around topics that influence AMR and national action plan. So one is governance, awareness, and education. There's one on data for action through this disaggregated surveillance and research, prevention, one on access to essential healthcare services, and one on timely and accurate diagnosis, and lastly, appropriate quality assurance and diagnosis. So some of the recommendations are very specific to preventing infections and addressing AMR, whereas others of these are more general, like access to healthcare services and distribution of resources within family. So it's quite a broad one. Some of the recommendations are very specific to AMR, whereas some are more general. Next one, please. So just to provide some kind of baseline data, a review of national action plans on antimicrobial resistance back in 2023 showed that out of 145 published national action plans, 125 did not mention sex or gender anywhere in the document. As already mentioned, AMR research indicate that gender influence exposure and susceptibility to infections. It also influences healthcare seeking behaviors and access to healthcare. And it also influenced greatly the pattern of antimicrobial prescribing and use in the population. Gender also impacts access to resources in the families and altogether, and the decision-making power for care and treatment on drug-resistant infections. And the gender disparity contribute to differences in quality of care received, and the patient outcomes was also part of the conclusions. Next one, please. So this is figure 2 from the publication, which shows the theory of change for addressing gender inequalities in national action plans and AMR. So the problem statement is that the national action plan do not recognize gender inequalities and how these impact the emergence and spread of AMR. And some of the recommendations, pathways to change, is to ensure that there is sex disaggregated data and research so that it's possible to develop evidence-based recommendations, that there is equal gender representation in AMR governance structures, ensuring that there are men and women, and then targeted awareness and behavioral change interventions that may have a gender lens in how things are communicated. Also, another one is addressing the gendered barriers to access to healthcare services, and that goes for both prevention, diagnosis, and treatment, and then ensure gender responsive legal frameworks, regulations, and guidelines. And of course, the desired outcomes would be increased gender responsiveness of national action plans on AMR interventions, and more women presented typically in the AMR decision-making bodies, increased awareness amongst targeted populations about AMR, and increased awareness amongst the healthcare system, healthcare workers, on gender-specific needs in addressing AMR. Also increased availability of data, both on resistance and use of antibiotics, and then increased evidence from research on AMR and the gender dimension. A specific focus was on reduced mortality, maternal mortality due to drug-resistant infections, including sepsis. The desired impact would, of course, be to strengthen the evidence base for gender and AMR and to reduce the gender-related inequalities in design, implementation, and monitoring of AMR interventions. And lastly, of course, very concrete outcomes in reducing morbidity and mortality due to infections by applying this lens. So this is the theory of change in the document, really trying to show the process of what is trying to be achieved and how this will be achieved. Next slide, please. I'm only going to share the overarching 3 top recommendations. But the first one is to start capturing disaggregated data on AMR and make sure that the minimum variables collected are sex and age, and where possible, also other social stratifier. For instance, the STG on referring to antimicrobial resistance are not stratified by sex. So I think there's a great piece of work in just making sure that we have the data stratified so we can do the analysis and develop the evidence needed to make policy changes. The second one is the short-term review existing national plans and try to put a gender equity perspective into these plans. And then the third one is to promote research to strengthen the evidence base on the intersections between gender and AMR, because currently there are very few and scattered studies and research in this area. Next slide, please. So basically this work, the WHO work, was a call to apply a gender equity perspective in healthcare delivery and services, and to collect and analyze sex disaggregated data, zooming in on antimicrobial resistance. And as you can see from the presentation, this is really work in progress still. Next one, please. So just to conclude, AMR and gender is highly relevant to WHO's goal of achieving antimicrobial treatments that work today and in the future. And one of the steps is the recently published guidance that I shared with you. I can recommend to have a look at it, and to continue focus and prioritization of gender is really needed to ensure that policies address men and women in AMR prevention and control. So thank you very much. Next slide. Okay. So this I can recommend. If you go to the WHO Euro website, there are stories from different actors around Europe on AMR, and it's all the way from patients to lawyers to physicians and the agricultural sector. So I can really recommend to have a look at the WHO website to read some of these stories, because they give a very good One Health perspective on AMR. Thank you very much.
Thank you very much, Dr. Team. That was excellent and stellar, straight to the point. Thank you so very much. I really enjoyed every bit of it, and I think we have to move to the next segment of our meeting today. Ladies and gentlemen, if you have any question you would like to ask, please do well to use the chat box. Drop your question in there, and let's take the question so that we can ask our presenters for clarity on subject matters that are of great concern and interest to us. So it's time for question, and if you have any, I really would love to take it up from there and make sure that the speakers lend their professional advice and expertise on this. But to start with, Dr. Tin, from your presentation, we have just a key question we'd like you to attend to. You talked about the role of gender inequalities in antimicrobial resistance national action plan. And one question that came up is, how does gender inequality practically affect the success of AMR? How does gender inequality practically affect the success of AMR interventions? So all speakers will be spotlighted so that we can see your face and be able to hear your honest feedback on this.
Okay, so sorry, I think I'll try to repeat the question because I'm not sure I heard. How does gender affect implementation?
How does gender inequality practically affect the success of AMR interventions? So that was the question that came in.
Well, one example could be that, for instance, urinary tract infection is something that affects basically half of women in the world. Today, in many settings, we have very little research going on rapid diagnostics and rapid susceptibility testing, and this may have very, very severe consequences for the women living with urinary tract infections. Another example is we know that women are more likely to use antibiotics in their life's course. There's been very few studies. One show that women use 27% more antibiotics than men. In my view, it's probably underestimated. But when you look at the prescribing patterns, women are less likely to receive antibiotics when they go and see a physician. And depending on the physician's sex, they may be less likely or more likely to prescribe to the woman. So, I mean, there are a whole range of different areas that are affected by not having the data stratified, or the more detailed data. It goes for the research and it goes for the implementation, especially concerning access to healthcare, which is a key, very, very much important for antimicrobial resistance and implementing proper stewardship in the sector. So I don't know if other colleagues want to comment, because you have more national experience on these issues.
Dr. Anuj, Dr. Gitanjali, do you want to lend your voice on the question, or we move on straight to the next one?
I can maybe just...
Gitanjali, please go ahead.
Okay. Thank you. Yeah, so we were doing a study in Africa, and this was a Fleming Fund study. And in that study, basically, it was covering 14 sub-Saharan African countries. We were looking into, whether males or females, which gender was more impacted with resistant infections. Again, this was a pilot, so much more work needs to be done to really arrive at some kind of a conclusion. But yes, we did see males were more affected with resistant infections. And the reasons that actually came up was because they are mostly, outside, getting more exposed. Women are mostly indoors. Yeah, so that was one of the reasons. And also they go for health checkups also. So, multiple reasons are there. But as I said, this is too premature. It can change from setting to setting. In some settings, yes, it could be that way. But in certain other settings, it could be, because even for women, they do go for their for routine checks, especially in pregnancy. So that's one time when any infections they're harboring can be captured. So no clear-cut answer here, but it's an area of upcoming research for sure.
Thank you so much. Okay, Dr. Anuj, we have a question for you on the chat. It says, what has been your experience with engaging major corporate hospital chains in India to bring them on board? And what are the main challenges in engaging and retaining private stakeholders?
Before I answer that question, just to share, at the recent meeting in Delhi, there was a strong, focus on, there was a professor from the National Disease Modeling Consortium at IIT Bombay, who talked about the gender aspects of AMR and the data that they have from across India. They have noticed clear differences in AMR, and especially if you're looking at gender disaggregate data, especially age-wise disaggregation. Overall data may not hides a lot of the disparities. So you need to look at age disaggregated data to really find out the disparities, especially during the reproductive age group, etc. Also, recently, the regional office had organized gender is an emerging area of concern, and the regional office, I think the regional quadripartite recently had a workshop on mainstreaming gender into the AMR response. Coming back to this question on engaging corporate hospital chains. Now, a lot of these corporate hospital chains are already well engaged in AMR containment for their own, on their own, primarily from the economic perspective. An AMR infection leads to a longer hospital stays for these private hospitals, and they lose money on an ICU bed being occupied for a long duration. So all of them have very strong infection prevention and control, diagnostic stewardship, as well as antimicrobial stewardship to ensure AMR is well addressed in these private chains, because a lot of these hospital chains are JCI accredited. All of them are NABH accredited. So accreditation puts a strong focus on antimicrobial stewardship and the AMR response, various domains of the AMR response. Having said that, at the end of the day, all of them are in the business of providing healthcare. And other than the trust-based private sector hospitals, most of the others do not like to share their data. So data sharing is a huge issue from the private sector because they don't want to be seen as having high levels of resistance, etc., especially the healthcare-associated infection data. So we have sort of had engaged some of these Apollo hospitals and some of these bigger chain hospitals in the AMR surveillance networks. Some of them are still part of these state-level AMR surveillance networks, and a couple of them are part of the ICMR's AMR research and surveillance network. So some of them are well engaged in the AMR containment response at the national level as well as at the state level, but there are challenges. A lot of them do not want to share data, which either pinpoints their weaknesses or the high levels of resistance, etc. So I think there are these challenges, but again, these are challenges which can be overcome. And Kerala, has a strong public-private partnership. So they have engaged the private sector hospitals also in the state AMR surveillance networks and the AMR response. Back to you.
Yes, thank you very much, Dr. Anush. So while I was listening to you, another question actually came in, which I would like you to quickly attend to. And the question is, how do state action plans differ from the national action plans, and how do they coordinate and share data, if at all they do share data?
I think I saw Dr. Jyoti Acharya had posed this question from Nepal. And in the state action plans, they have state government ownership, but they have strong oversight and they are well aligned with the national AMR program. And the information is shared. Data is not really shared, but they are well coordinated, and data for the AMR and the other aspects are shared through official channels. And just a case in point, all the data from the state AMR surveillance networks is shared with the NCDC AMR surveillance networks, whether it is NARSNet or NACNet. And the national level, the NARSNet data plus the state AMR data then is coordinated and shared globally by National Center for Disease Control with the WHO Global AMR Surveillance System. So data sharing mechanisms are in place.
Perfect. Thank you. Professor Gitanjale, this one is for you. You know, in the course of your presentation, you talked about PPE as a core requirement for IPC. And the question is, how can hospitals maintain IPC standard when resources such as PPE and water are limited?
Yeah. So again, IPC is not something which is one person's business. It's something which includes everybody in the administration. They need to be also involved. It's just not the work of an infection preventionist or a microbiologist. Most important is having a leadership, political will, as well as funding dedicated for sustaining a IPC program. So we may talk about anything, but if we don't have, especially for government setups, this is really important. They need to give time to attend these meetings, and I'm speaking from some real examples which we are seeing these days. We have IPC committees, but they're rudimentary. Either the team is not having the expertise, the right people are not on board, and above all, the institution heads, they are maybe not even aware of it. So we need everybody to be on the same forum, give time for these meetings, and address any challenges. Funding, of course, is very important. We need to have, so whether it's your PPE or it's having a sterilization system in place, coming up with occupational hazard containment, all this does need investments. So yes, that's where we come from. Even infrastructure upgradation.
Okay, great. But then, from your experience, are there some low-cost strategies that you have seen that made the biggest difference in improving IPC in LMIC?
Yes, the biggest difference actually comes from very simple interventions, and that's hand hygiene. That actually really helps. So even if, circumstances may not permit us to go and have big setups, but even simple training programs, if that can be organized and we can train our support staff and our rest of the healthcare workers with practices of following the WHO 5 moments of hand hygiene, ensuring running water is there, power supply is there. These things itself, they are actually the foundation, or they are the pillars of building up the larger IPC program. Many of the practices, they need not be done on ground under the same roof. They can be outsourced. For example, if you don't have a CSSD, that's Central Sterile Supply Department, that's the sterilization of instruments. If you don't have it in-house, due to whatever constraints, that can go out. But in-house for sure, if you can just, follow meeting the low-hanging fruits, ensuring your basic utilities are there, running water, soap, disinfectants. It really goes a long way in preventing
Making a big
infections.
difference.
Yeah.
Yeah,
And
thank you.
vaccinations also. Yeah.
Yeah, thank you so much. Dr. Tin, now this one is for you. You know, you talked about addressing gender inequalities, and there's no way we can address gender inequality if there is no inclusivity in all of our strategies. So we're wondering, how can we ensure women, especially in rural and underserved communities, benefit equally from antimicrobial resistance intervention?
That is a really, really good question. I think I'll revert to what Dr. Sharma was saying before, which I think is really important, that we need data. We don't actually necessarily have very good data from which we can build good policies and good interventions that really target different groups more, better, more cost effective, in a higher impact way. So I think there's still a long way to go in order to reach really the periphery. And I think really we need to keep reminding ourselves that the WHO resolution from 2007 is still not implemented. It's not implemented in the Sustainable Development Goals. And when you look at data, we did a piece of research in WHO Euro looking at indicators for many, many things, and less than half are stratified by age and by sex. And we need this kind of information in really to make sure that we can target. So I don't have any good solutions. I think there is evidence, so we shouldn't sort of back off and not start doing things. But I would keep on saying that we still need to make sure and repeat. We need the age, at least age and sex disaggregated data whenever we do research, whenever we do surveillance, whenever we do any kind of data collection, in order to be able to make the best strategies and interventions. So unfortunately, I have no magic bullet on how to reach the very periphery. I mean, my colleagues who are working more at the peripheral level have some good examples.
Great. Thank you so much, ma'am, for your thoughts. Dr. Anuj, you are smiling, and I feel maybe you have a comment you would like to lend to the question. But before you do that, let me quickly present this to all of you. It's in the chat box, but we don't know who the question is that specifically addressed to. The attendee is asking, what are the key studies on research area that India and other Asian countries are currently lacking in implementing effective One Health programs? Additionally, what factors need to be addressed to tackle antimicrobial resistance in the context of increasing population pressure in this region? That's a question from an attendee. Unfortunately, it was placed in the chat box, and we have to pull it out, and present to you. So, Dr. Anuj, please, can you take the lead on this?
So a lot of research is actually going on, but certain areas still need attention. And one of the key areas of research is estimating the economic impact of antimicrobial resistance, especially at the national level and the subnational level. Because if we are able to show to the policymakers, the reason some of the policymakers in some of the states are moving forward, they realize the impact of AMR, not just the morbidity and mortality, but also the economic impact of AMR. And to get the other stakeholders where we are not sort of, AMR is not moving in a large number of countries. I've worked in Southeast Asia and the Western Pacific region. And I can tell you a number of countries are not working on AMR. And even the work in India is patchy. We have a lot of work going on in Kerala and some of the good states, but some of the other states are lagging behind. And one of the key areas of research would be if we can answer what is the economic impact of AMR for a state, for a hospital, for a farm, for the animal husbandry sector, for the fishery sector, in particular defined geographical areas, whether it is at the national level, state level, or at a even sub-state level. So that is something I feel is critical. Of course, a lot of research is also needed in newer innovations for AMR containment. A lot of work is happening on newer drugs and diagnostics, etc. So I will not focus on that, but looking at innovative approaches to contain AMR is something where a lot of research is still needed, although a lot of work is going on.
All right, thank you, Dr. Tim.
Yeah,
I can see your hand.
maybe I can just comment, because I couldn't agree more. When I was still with WHO Euro, we were working with the quadripartite on piloting, estimating the economic burden of AMR from a One Health perspective. Methodological, it was very challenging. I know it's being pilot in Georgia at the moment, which is not a very big country, but there are a few pilots around the world, and I'm still very much looking forward to seeing the result, because I very much agree we need to make things very concrete and flag the economic impact to really drive change. And then I just had another comment on the innovation side. In the WHO European region, there's been a very strong history on using bacteriophages, bacteria that kill viruses, for the last 100 years. And the world's biggest research center is in Georgia. And this is one of the technologies, it's vintage innovation, it's new and old, that's really gaining a lot of attention at the moment. And I think it's very important that when we talk about innovation, we think broadly, because the molecules, new antibiotics, it's a very thin pipeline as it stands right now. So I think we really need to broaden our mind and think about whatever. It could be UV light, it could be, other approaches to bring down the load of infections, optimizing vaccines, other ideas about how to tackle, and not only focus on development of new antibiotics, because within a few years there will be very great resistance. So I just wanted to flag, in WHO Euro, we did this initiative on vintage innovation, and it gained a lot of attention. More than 1,400 signing up for the webinars, and really a lot of attention altogether. So yeah, just a comment on the innovation part.
All right, thank you very much. Dr. Gitanjali, do you have a comment you'd like to lend on this?
Yeah, I think I would like to add the importance of strengthening data management systems, because that is really critical. All the research which I've actually been leading, I feel the biggest factor that really helps us in giving good results is as good as the quality of data we are collecting. So we had lots of information we got, but it was mostly from paper based records, and then transcribing it, making sense out of it, it's not all that easy. So a lot of data gets wasted. So we definitely need to move to electronic systems, and that's something which should be an emphasis as we try to strengthen AMR mitigation practices. Thank you.
Nice. Okay, thank you so much. So before I let you go, Dr. Gitanjali, there's a question for you in the chat, and it says, is there an established active IPC committee at the global or regional level that you would like the audience to be aware of at the moment?
In India, are we talking about that? Yes, we do have two national bodies that are leading the IPC efforts in the country. We have it from the ICMR, Indian Council of Medical Research, and we're also having it at the level of NCDC, National Center for Disease Control. Globally also, we have lots of great information from the US CDC, from NICE, from the British standards. So all these information actually is handy, but of course it's important to realize you need to customize it as per your setting. We also have in India NABH, NQAS, and other Indian public health standards, which also give guidance. So again, it's a mix and match we need to do, but the pillars, the skeleton does not change, just like old wine in new bottles. So you need to see what best fits in your context. Thank you.
All right, thank you so much. Before we draw the curtain, I would like to serve this question to all of you, Dr. Anuj, Dr. Gitanjali, and Dr. Tin. And the question is, across your different focus areas, what is the one practical action, what is the one practical action countries can take right now to strengthen antimicrobial resistance response in low resource setting? If you missed that, I'd like to repeat the question again the way it came. Across your different focus areas, what is the one practical action countries all over the world can take right now to strengthen antimicrobial resistance response in low resource settings? I'll start with you, Dr. Tin, as you are on my top left-hand side, and what is your perspective on this? And also that will be your closing statement before we draw the curtain. Thank you.
Well, I have three comments for that. One is, of course,
Okay.
a very low cost one, which is to make sure that you have sex and gender segregated data. That's one.
Okay.
I think IPC is the best. IPC is extremely important. It's a low cost, high impact intervention. Yeah. And then lastly, I would like to flag the One Health approach. It's complicated, it takes time, but it is a One Health challenge. And we need to involve every sector, environment, agriculture, human, and also the public and the private, which is, I'm very happy to hear about, well, that there is communication, but I think often we tend to forget the importance of the private sector and really ensure that this is handled as a holistic problem in order to really address it. Thank you.
Awesome. Dr. Anuj, what's your take on this?
So I would say three things. Of course, first, I agree. I think infection prevention and control is a low-hanging fruit for the LMICs with the high burden of communicable diseases. Focus on infection prevention and control across sectors will have a tremendous impact, including the use of vaccines to prevent infections. Also, having national action plans on infection prevention and control in alignment with the Global Action Plan and monitoring framework on IPC, which was endorsed by the World Health Assembly last year. So all countries need to develop their own national action plans. So first is IPC. Second, I think for the low resource settings is having diagnostic stewardship coupled with data management in terms of having good quality data from not just the laboratories, but also the pharmacies. So AMR and antimicrobial consumption and use data, which is then converted to useful information for policy making. And of course, third is optimizing antimicrobial overuse and curbing overuse and misuse through antimicrobial stewardship, not only in human health, but also in the animal husbandry and the aquaculture sectors.
Nice. Thank you so much. Finally, Dr. Gitanjali, what is your take on the question? From your area of specialty, what is one action that you think countries all over the world should take at the moment in order to address the challenges of antimicrobial resistance effectively?
Yeah, I agree with what Dr. Anuj and Dr. Chen just mentioned. Definitely, those are great points. I would like to add upon the importance of strengthening the governance system. So we definitely need to have the right people on different committees, and again, not working in silo, but together across these. Now, this concept of One Health has come. It's also great, but it's also a very complicated thing because now you don't just talk of one sector, but across sectors. So maybe not One Health, but it's a 4 health sector. So you need the right governance out there to join all the dots, and also importance of regulations, just not having it on paper, but ensuring that it's getting implemented. That's also important. So 2 points from my side out here.
Thank you, thank you, thank you, thank you, thank you. That was excellent. Ladies and gentlemen, if you are just joining us, this is the World Antimicrobial Resistance Awareness Week webinar put together by the Antimicrobial Resistance Knowledge Hub and Community of Practice of the Global Health Network, holding today, the 19th of November 2025. It's been wonderful having all of our resource persons on the call today. They are experts in their given field, and they have shared their thoughts on what we can do collectively to address the challenges of antimicrobial resistance in Asia and in our own country, wherever you come from. Yesterday, we were in Africa. Today, we are in Asia. Tomorrow, we are going to another country in Africa. We are going to Nigeria. And as you can see on your screen, we are extending this invitation to you. Kindly make our time to join us. If you haven't registered already, kindly use the QR code on your screen to register and get plugged in so that you can join us tomorrow for another impactful presentation on the subject matter of antimicrobial resistance. We have our colleague, Dr. Hamza, on the call, who is going to give the closing remark. Hamza, if you are ready, we are ready. Over to you.
Hi, Ohemo, can you hear me?
Yes, we can hear you.
Okay, fantastic. Thanks everyone for joining us today for this webinar. Apologies for my laptop just switched off exactly when I was about to speak. So some technical glitches, but we are going strong. So in conclusion, we have all gathered here at a very critical moment in global health. AMR is no longer a distant threat, it is a present reality, especially across Asia and Africa, where the populations, as many people in the chat also mentioned, the populations are large, health systems often under huge strain. The impact of AMR is already being felt in devastating ways. Global leaders have recognized this urgency. There was a resolution passed last year by the United Nations General Assembly underscoring the need for coordinated action. Yet, despite these commitments, irrational use of antibiotics continues, with some communities facing lack of access, while others struggle with overuse. You've heard our speakers, the very nice highlights they've given about AMR and the experiences they've shared both from national and global scenarios today. If you take India, for example, is the largest consumer of antibiotics in the world. But when we take a look at the per capita consumption, it remains low, reflecting inequities in access. And tragically, children are the most vulnerable, they are the most affected, and many lose their lives because life-saving medicines no longer work as they should. And this is the reason why our speakers highlighted the usefulness of age and sex disaggregated data. So today's discussions highlighted the realities from different perspectives, from surveillance and stewardship to innovation and equity. Each presentation has left us with one clear message, that is, no single sector, country, or institution can solve AMR alone. Everyone needs to work together. We need to work together, whether it's advocacy or implementation research or gathering data, the missing data gaps on gender for the next action plan, everything. With that, and hoping that we can all work together in a very coordinated manner to tackle AMR in the coming years. I would like to close this webinar, and I look forward to the insights and collective energy you will spread across and you will share with your colleagues in the coming days to tackle one of the greatest health challenges of our time. And just repeating the WHO's theme for this year, which is Act Now, Protect Our Present, and Secure Our Future. Thanks so much, everyone, for joining today. And please have a look at the links shared for ensuing webinars, even the one tomorrow for Nigeria on AMR, and the other webinars that TGHN freely hosts, so we could capacity build and we can share the knowledge and update our activities for global health. Thank you so much. Thanks to all the speakers.
Thank you. Bye.
Thank you so much. Thank you so much, Hamza. That was wonderful. And colleagues, we are very grateful. Words are not enough to express how grateful we are to have you on the call with us today. I believe you've been challenged. I believe you have been inspired in one way or the other to look at how we can address the issue of gender inequalities in our National Action Plan for Antimicrobial Resistance, how you can set up IPC, and how you can get the government and state involved in addressing the challenges of antimicrobial resistance. As we said earlier, tomorrow is going to be another day, and we really would love to have you on the call with us. We'll be traveling all the way to Nigeria for another impactful conversation on AMR. And the theme is Act Now, Protect Our Present, Secure Our Future, and we are spotlighting Nigeria. Everybody is invited, whether you are Nigerian or not, as long as antimicrobial resistance affects everybody. Everybody needs to come discuss, come learn, come unlearn, and come relearn on the subject matter of antimicrobial resistance. So on behalf of every one of us at the Global Health Network, we want to say thank you so very much for being here, and we look forward to catching up with you again when next we have another webinar or when next we will reach out to you. Do have a wonderful morning, do have a wonderful afternoon, and do have a wonderful evening, depending on your time zone. Bye for now.